I was asked to provide a view on the way forward for randomized clinical trials, RCTs. So RCTs we know from the pharmaceutical world, and what I would do in this talk is to see what needs to happen when we apply this to robotic-assisted surgery techniques. Essentially, RCTs, obviously, as most of you will know, is the most reliable source of scientific evidence. So it's it serves us well. It has served us well, and it's still serving us well. Predominantly in the field of pharmaceuticals, where you set up a control arm and then an active arm, and where you compare, where you test the hypothesis whether you have an improvement or not. That works well if you have, and we control for patient heterogeneity, so we try to eliminate all biases, and that is what is happening most of the time nowadays. However, well, what's the however? Well, a weak point of RCTs is the fact that you have a very high internal validity, but the external validity, so the extent to which they can cope with any environment beyond the environment in which your technology, in casu the pharmaceutical, has been tested, differs from each other. In that case, and that is the case actually when you apply this to surgery, that you might have a problem. So typically, what is the problem then? Well, you might say that typically RCTs report averaged outcome data or average performance data. They do this in Kaplan-Meier plots that are cohort based, so everything is averaged out, the whole heterogeneity is, let's say, averaged out and focused on the test population. Now, if you want to apply this to robotic-assisted surgery, then there are some recent publications that point us to a problem that you might have, which is, well, actually robotic-assisted surgery, here the solution is not a pharmaceutical technology, but here the surgery is actually a combination, I would say, of a device, of a robot, together with a human being the surgeon in question. And if you are going to set up, let's say, with the necessary power, a whole trial, then you will have a mixture of higher and lower proficiency surgeons that serve, let's say, the heterogeneity of the patients. Now, of course, this latter heterogeneity is not modeled typically in these RCTs. So that means that you get to outcomes that may be valid for an average, but there is not such a thing as an average surgeon. So there's always like a one specific person, and we want to know what the effect is related to the standard of care. If you have, let's say, a high proficiency surgeon within a lower proficiency surgeon, for example, that needs to be taken into account. So not averaging out, or so that means that we need to stratify the population, so essentially. So not the patient population, but the surgeon population. So averaging this out helps us to do what? Well, to learn, basically. So we can learn from the operational procedures that we are conducting. And for this, you need to set up what I call then a surgical learning system. And the surgical learning system is a data-based system. So you would have to record, let's say, your data, the outcome data that you have, maybe some process data that you record in a registry. And based upon these, you can do not a cohort analysis. You might, but you could also drill down deeper and, for example, aggregate the results to a certain patient base, or aggregate the result towards higher proficiency people, or maybe aggregating towards a center if you have several of these centers that register their local data into a network upon which you do your overall analysis. And that is basically, I think, the way forward for RCTs. So RCT-based studies become what we call our WE-based studies, so real-world evidence studies that are being fed by, let's say, a network of databases in which you record data on a certain physician treating his or her patients, that being documented, and then you can or let's say there's two ways that you can learn from the data. In artificial intelligence, so AI, machine learning methods, we distinguish between what we call unsupervised and supervised learning. Supervised learning is the easiest. So there you do your hypothesis testing or generation, like in RCTs, basically, where you say these are the variables upon which I want to have an outcome. And unsupervised learning is the most advanced, I would say. So there you essentially feed the system with data, and you see whether there are patterns that are popping up after a while. But that implies, of course, that also in contrast to classical RCTs, where you basically scoop data in one go into one project, that you have, let's say, a continuing feeding of data. So you have longitudinal data that is being recorded in your databases, and that can be used then to do your analysis and to see how, let's say, the different surgeons are advancing on the learning curve and how they get from one proficiency level to another proficiency level. Maybe a final point, I think. So obviously it is clear that for the patient we want to have surgeons that are, let's say, certified in the operational procedures that they can handle with proficiency. But for us as analysts, it's also important, I would say, certification provides us with a mean to stratify the population, because of course if we record this into our data sets, then we can see for a certain certification level how do people perform, and we can easily make comparisons and correct statistical comparisons. This in opposition to if you only have, let's say, an overall cohort-based analysis where you just can say, like, go and see the most proficient or the most experienced surgeon, which is kind of stating the obvious, I would say.